Welcome back to the Deep Dive. Today, we are really focusing in on two anxiety disorders, super common in the clinic, but they've got these subtle yet really crucial differences. Get them wrong, and, well, treatment can stall. So we're synthesizing the high-yield stuff on social anxiety disorder, SAD, and generalized anxiety disorder, GAD.
Yeah, and the goal today really is clinical precision. For you as residents, right on the front lines, you've got to move past just, spotting anxiety.
Yeah.
You need to know how to accurately tell these two apart and critically how to separate them from things that look similar, like certain personality issues or even psychotic disorders. Because the treatment path, totally different.
Okay, let's dive in, starting with SAD. If you boil it right down, what's the core engine?
The core fear in SAD, it's intensely specific. It's this deep fear of embarrassment or humiliation in social spots where you feel like people are watching you, scrutinizing, judging.
So the anxiety is really driven by that fear of external criticism.
Exactly. And just to give some context for your practice, the lifetime prevalence isn't small. We're looking at maybe 3% to 13% of people.
Wow, that's significant.
It is. But here's the thing that often trips people up. The big population studies. They show it's about twice as common in women.
Wait, okay, so studies say more common in women, but clinically, you often hear about more men seeking treatment. That's that gender paradox, right? How do we explain that?
That's a great point. It's important to clarify. It's probably not about the illness itself being different between genders. It's more likely about, well, who actually comes in for help?
Help-seeking behavior.
Exactly. Men might feel more pressure to seek treatment, maybe if the anxiety really starts hitting their job performance hard, or sometimes substance use pops up as a way to cope, and that brings them in.
Makes sense.
And also, timing the onset typically spikes during adolescence. Right when social stuff becomes super important. And don't forget the family link. It's about 3 times more common if a close relative has it.
Okay, let's hit those key DSM-5 markers. So, if the core is fear of judgment, the symptoms they're afraid of showing must be things others can see, right?
Precisely. Things like blushing, maybe stammering, visible shaking or twitching. It's the fear of that being seen that fuels the avoidance.
Got it.
And critically, if you're working with kids, it looks different. The anxiety has to show up around their peers, not just with adults. And what you often see isn't verbal worry. It's more like crying, tantrums, freezing up, clinging, or just flat out refusing to talk.
Right, not the same as an adult worried about giving a presentation.
Not at all.
So sticking with this idea of external criticism, what about that specific performance-only subtype? That must really shift the picture.
Oh, absolutely. And getting this distinction right is vital. It actually changes your medication strategy.
How so?
Well, this is someone who might be totally fine at a party, chatting easily, but put them on a stage or ask them to speak in a formal meeting, the anxiety just skyrockets.
Right.
Their fear is laser focused on that act of performing. And crucially, the physical symptoms, the shaking voice, the sweating that might give away their nervousness.
Okay, this is where clinical precision really counts. Let's differentiate SAD from the conditions it gets mixed up with most often. Maybe start with agoraphobia and panic disorder. They seem like close cousins.
Good place to start. The key difference is the source of the fear, or maybe what makes it better or worse. Think about having someone with you. For someone with agoraphobia, having a trusted companion often reduces the fear. It provides a sense of safety in those feared situations, like open spaces or crowds.
Okay.
But for SAD, it's the opposite. More people means more potential judges, so having others around actually intensifies the fear.
Right, that makes sense. More eyes on them. And what about the symptoms themselves during an episode? That seems like a big clue, too.
Huge clue. A full-blown panic attack, you're usually talking internal sensations. Can't breathe, dizzy, choking, feeling unreal, maybe terrified they're dying.
Very physical, very internal.
Whereas with SAD, the focus is on those visible signs of anxiety, the blushing, the trembling, the sweating that others might notice. And here's a really critical clinical question you got to ask.
Okay.
If someone avoids public speaking only because they once had a sudden, out-of-the-blue panic attack while doing it, the primary diagnosis is probably panic disorder, even though the setting is social.
Because the fear is about the panic attack itself recurring, not about the audience's judgment.
Exactly. Fear of the internal collapse, not the external critique.
Okay, moving down the list, personality disorders. SAD and avoidant personality disorder, AVPD. These seem incredibly similar on the surface.
Yeah.
How do we reliably pull them apart?
Timeline. Timeline is your friend here. AVPD is usually pervasive, meaning it's been there a long time, often since childhood. You see this pattern of shyness, withdrawal, being a hypersensitive to criticism, pretty consistently,
Right, it's more of a lifelong trait.
whereas SAD typically has a clearer starting point, usually in adolescence. Now, compare that to schizoid personality disorder. People with schizoid traits, they do generally have little interest in social interaction, they prefer being alone, but crucially,
They aren't afraid of it.
exactly, they don't experience that fear or anxiety about judgment that defines SAD. It's more like indifference, not dread.
Okay, that's a clear line. But what if the social avoidance is hinting at something heavier, like early psychosis or really severe depression?
That's when you have to assess their insight, their reality testing. In early schizophrenia, for example, the avoidance might come from paranoia, like they think people are plotting against
So
them.
the reason for avoidance is different.
Totally different. And importantly, people with this SAD usually know their fear is excessive or irrational. They might say, I know it's silly to be this scared ordering coffee, but they feel it anyway. It's ego dysphonic.
Yeah.
With major depression, the withdrawal isn't typically fear-based. It's more about having no energy, no interest anhedonia, energy, rather than a specific fear of being judged.
That's super helpful for sorting things out. Okay, let's pivot now. We've talked about the specific fear in SAD. Let's move to the constant pervasive worry of GAD.
Right, GAD. This is anxiety about, well, pretty much everything, often without a clear trigger or way out of proportion to the actual situation. And the key DSM-5 criteria. This worry has to be persistent, hard to control, and happen most days for at least 6 months.
6 months. That chronic nature, like a constant background hum of anxiety.
Exactly, that's a good way to put it. And like SAD, GAD affects around 5% lifetime, also about twice as common in women. Onset, usually late teens, early 20s. But here's something really important for you, especially if you're doing consults.
Yeah.
These patients often show up first at their primary care doc's office or, a specialist, not psychiatry.
Because of the physical symptoms, right? The somatic stuff often takes center stage.
You got it. They come in complaining about being tired all the time or chronic stomach issues like IBS or diarrhea, maybe muscle aches and tension that just won't quit. The underlying GAD, that pervasive worry, often gets missed until someone specifically asks about it.
So you really have to probe for the worry itself. Okay, let's get into the weeds a bit, the neurobiology. Understanding this helps with choosing meds, right? What systems are we talking about with GAD?
Yeah, absolutely. The big players are GABA and serotonin. We know benzodiazepines work primarily as GABA receptor agonists. That's why they calm anxiety down quickly. But here's a fascinating detail.
Okay.
The highest density of GABA receptors. It's not spread evenly throughout the brain. It's particularly high in the occipital lobe.
The occipital lobe, that's primarily visual processing, isn't it? How does that connect to generalized worry? That seems specific.
It is specific, and honestly, we don't fully understand the why yet, but it certainly raises questions about how widespread anxiety maps onto brain structures. It feels like an area ripe for, future research and maybe more targeted therapies down the line.
Interesting.
And then on the serotonin side, that's where drugs like buspirone come in. It's a partial agonist at the 5-HTRA receptor, gives us a different angle, a non-sedating option that doesn't work through GABA.
Okay, so besides the core excessive worry, what else do we need for a GAD diagnosis? Give us a quick symptom checklist.
Right, so you need the worry plus 3 or more of these. Feeling restless or keyed up, getting tired easily, trouble concentrating like your mind going blank, irritability, muscle tension, or problems sleeping.
3 or more of those 6?
Yep. But remember, for kids, it's different. They only need one associated symptom plus the excessive worry.
Okay, treatment. We know for both SA and GA, usually the best approach is a mix, right? Therapy plus medication.
Yeah, combination treatment generally gives the best outcomes. But let's break down the meds first. Are the first-line choices the same for both? Not exactly. For SA, it's pretty clear-cut. SSRIs are first line, no question. For GAD, the options are a bit broader right out of the gate. SSRIs are still a mainstay, but so are SNRIs like venlafaxine and also buspirone.
And older meds.
Older agents like tricyclics, imipramine, for instance, they can be effective. But because of side effects, they're usually not the first pick anymore. More for cases that haven't responded to other things.
Okay. Now let's circle back to that specific situation we mentioned, the performance-only SAD subtype. You said the med strategy changes. What's the deal with beta blockers there?
Ah, yes. This is sort of the classic stage fright intervention. Beta blockers like propranolol, maybe 20 to 30 milligrams, or tenolol, 50 to 100 milligrams. The key is you take it about an hour before the performance.
And how do they work?
Critically, they work mostly on the body, not the brain. They block the physical symptoms of that adrenaline surge. The racing heart, the shaky hands, the sweating, they don't really cross the blood-brain barrier much, so you don't get sleepy or foggy.
So they stop the physical evidence of anxiety, which is what that person fears showing.
Precisely. Takes away the proof.
Okay? And then, benzodiazepines. Everyone knows they work fast for anxiety, muscle tension, feeling wired, but the downsides are significant.
Oh yeah, paramount caution here, especially for you as residents prescribing them. The risk of tolerance needing more for the same effect and dependence is really high, so we have to be strict about limiting their use. Meaning, really, only two main scenarios for short-term use. One, maybe for the first couple of weeks when starting an SSRI, just to bridge the gap until the SSRI kicks in.
Okay, temporary relief.
Right. Or
Ugh.
two, strictly as needed, PRN, for really acute, overwhelming anxiety spikes,
Yeah.
not for daily, long-term management. That just leads down a bad road.
Got it. We talked about buspirone for GD. Any role for it in SAD?
Yeah, it can be useful as an add-on, an adjunctive medication. Say you've got someone on an SSRI for SAD, and they're better, but maybe not all the way there. Adding buspirone can sometimes boost the response. It gives you that extra push through a different mechanism, the 5-HTOA system.
Okay. And finally, how long do we typically treat these conditions, especially GAD?
Good question. For GAD, given its chronic nature, the recommendation is usually to continue treatment for at least 12 months, even after the person's feeling better, to help prevent relapse.
All right, let's switch gears to talk therapy. For social anxiety disorder, what's the go-to approach?
For PsyD, the strongest evidence is for approaches that combine cognitive and behavioral techniques. Specifically, exposure therapy is key.
Exposure, meaning facing the feared situation.
Exactly. Gradually, systematically confronting those social situations to reduce the fear response, that's desensitization. And then the cognitive piece focuses on identifying and challenging those negative automatic thoughts, like everyone thinks I'm awkward, or if I blush, it's catastrophic, restructuring those maladaptive beliefs.
Okay, so exposure plus cognitive restructuring for PsyD. What about Gary D, with his focus on that chronic worry? Is the therapy different?
It is somewhat different, yeah. While CBT cognitive behavioral therapy is still very foundational, particularly for targeting the worry thoughts themselves, the structure might vary. You also have other approaches that can be helpful. Insight-oriented psychotherapy, for example. This digs a bit deeper, looking for maybe unconscious conflicts or past experiences that could be fueling the chronic anxiety.
Exploring the why behind the worry.
Kind of, yeah. And then, of course, there's always supportive therapy, which is really about providing reassurance, validation, helping the person develop better coping skills for managing the day-to-day stress of living with GAD.
So several options depending on the patient and the focus. Okay, let's try to wrap this all together. Patient walks in anxious. How do you, the resident, synthesize everything we've talked about to really nail down that primary diagnosis?
You got to find the main driver. What is fueling the distress or the avoidance? Is it that intense, specific fear of being judged, embarrassed, humiliated by others, that external threat that points towards SAD? Versus are they just consumed by this widespread, uncontrollable worry that jumps from topic to topic, job, health, family, finances, often without a clear focus? That internal state of chronic hypervigilance, that smells like GAD.
Identifying that primary driver fear of judgment versus pervasive worry is step one for treatment planning.
Absolutely essential, because that guides your first-line choices both for meds and therapy.
And let's be real, these things often don't come alone, right? Comorbidity is huge.
Oh, totally. That's just clinical reality. GAD and SAD often coexist. And GAD frequently travels with major depressive disorder, too. So when you have both anxiety and depressive symptoms staring you in the face, figuring out which one is the primary disorder is absolutely critical.
Because that's what you target first.
That's what should anchor your initial plan, yeah.
That's a fantastic summary. Really highlights the complexity, but also the path forward in treating these very common conditions.
Absolutely. And maybe one final thought, something for you to mull over as you're reviewing charts.
Okay.
We touched on that high density of GABA receptors back in the occipital lobe and its potential link to GAD. If the future of psychopharmacology is about precision, how might we eventually leverage that specific neuroanatomical finding?
You mean move beyond drugs like benzodiazepines that hit GABA receptors kind of broadly?
Exactly. Could we develop something more targeted? Something that maybe modulates GABA activity specifically in that occipital region or related circuits to relieve anxiety? It's speculative, of course, but it's worth thinking about where the science might take us beyond our current tools. Something to ponder.